Hello, and welcome to this YouTube video all about adenomyosis. So my intention is to try and do one of these every single week and bring to you a different gynae condition that might help to explain for you what might be going on for your body, and also what you can do about it and how I can help you with that. So I'm going to kick us off with a condition called adenomyosis, and it's something that's not well known about. And there was actually an adenomyosis awareness, I think it was a day, or I can't remember what it was, a day or a month or something last month. And it really brought home to me how little, as healthcare providers, we understand. And the number of people who have commented recently on the TikTok video I did about this just proves my point that we don't know about it very well as a profession. We don't manage it very well as a profession, and there are lots of women out there who are suffering needlessly for years. So let me break it down. I won't go on for ages and ages, so hopefully it gives you some food for thought, and then you can go away and do your own research, or you can book in with me and we'll go through it together, see if I can help you with this, and I'll tell you how things that we can do later on. So what is adenomyosis? That's the first thing. Adenomyosis is a condition that causes lots of pain, generally during a period, but can cause pain at other times. And it causes pain that's much, much worse than normal mild period cramps. So unfortunately, what happens is people get told it's normal, that their period pain is completely normal, and they are in agony every month. And they might have to take days off of work. They might not be able to sleep properly. They might not be able to go to school, and it's really disruptive. It's incredibly disruptive. Now, it can also cause heavy periods as well. Not always, but it can in some women's situation. And the reason for that is because it can cause the uterus itself to kind of swell up, so become a lot bigger than it should be, or on scans they might call it a bulky uterus, and that is what causes the bleeding. Now, what happens is the lining of the womb has what's called endometrial cells. These are the cells that generate and shed every single month. Generate, shed, yeah. They find their way into the muscle lining of the womb itself, and this is the problem with adenomyosis. So what I'm going to do is I'm just going to show you my screen, because I think it's important that you have a little look at a picture. So here we go. Where's my picture? There it is there. So I don't know how easy you can see that, but essentially adenomyosis is these endometrial-like cells, which is this little yellow line here, finding their way into the muscle lining of the womb, which is this sort of pinky orangey part here. Now, you can have focal lesions, so little clumps. You can have clumps in scattered locations, or you can have lots of it kind of scattered all the way through the muscle. And you can have adenomyomas, so sort of cystic-like lesions inside the muscle lining as well. So everyone's adenomyosis will look slightly different. And this will also determine whether or not it's picked up on a scan. Because just because somebody has said your scan is normal, it doesn't necessarily mean you don't have it. It just means that perhaps it wasn't big enough to be detected, or the person doing the scan didn't know what they were looking for. So I'm just going to stop sharing that one. Now, when somebody, so what, I suppose what the next question would be is, what would be the causes of adenomyosis? Well, we know that it's not linked to endometriosis. So when I was first training, I was taught that you had to have endometriosis, which is a similar kind of condition, except it's within the abdominal cavity or anywhere on the body completely. So the same kind of endometrial-like cells, but elsewhere, not within the womb itself. So I was taught that you had to have endometriosis before you had adenomyosis, or vice versa. It couldn't be one without the other. We now know that's completely not true, and there are some people out there that have got both, and they are completely separate conditions. There are some people that are told they have adenomyosis, but then endometriosis is missed. And there are some people that say they've got endometriosis and adenomyosis is missed. So they're very separate conditions. They both cause pain, but they also have other symptoms that go along with it. So endometriosis it has got more effect on the entire body. I mean, you can still have that with adenomyosis, but with endometriosis in particular, you get a lot of brain fog and fatigue and things as well. So I'm going to do a separate video on that one. Adenomyosis is purely within the womb itself. So for some women, having their womb removed cures the problem. Now, I suspect that it doesn't always work for women because they've got endometriosis and that hasn't been detected. But if you ask somebody that's had their womb removed, they will say it cured me overnight. I mean, obviously having surgery comes with its own risks, but that's quite powerful, knowing that if you can have your womb removed, if you've been really struggling, that can be enough to cure the problem. So there's plenty of things you can do before you get to that point, but that is the ultimate end game situation. So if you don't need your womb anymore, you can have that removed. Okay, so that's kind of like our end stage. So causes could just be simple things like having your period. It could be that you have had some kind of surgical intervention. So you might have had a polyp removed, or you might have had a termination of pregnancy or a miscarriage. That can be a risk factor for it. It can be a risk factor having a cesarean section. You've had big operation to remove a baby. That can also cause adenomyosis. We also know that it's more likely to occur as you get older as well, but it's not just older women that get it. You can get it at any age. And I saw some really heartbreaking things in the comments where some women were talking about having hysterectomies in their 20s, which of course is not ideal because that's often when people are wanting to have a family. So yeah, there we go. There's the kind of main causes. So you've got the lining of the womb, the cells of the lining of the womb that find their way into the muscle lining of the womb where it shouldn't be. And that could be through natural processes, or it could be because of surgery. Okay, so that's essentially how someone might develop adenomyosis. Now, of course, if it runs in the family, you're more likely to experience this as well. Not necessarily in every case, but you have to bear in mind that family history does play a role. So how do we treat it? How do we manage it? Well, I think there are lots of different ways that you can look at this. Now, you can look at it from purely a medical perspective, but you could also look at it from what's called functional medicine. This is where you start to manipulate things using your diet and lifestyle. Now, of course, any condition can be improved immeasurably with improvements in diet and lifestyle. So if you are somebody that eats a lot of processed foods, a lot of sugar, a lot of caffeine, a lot of alcohol, smoking, if you cut all of those things out, that can really, really help. That can really give you a lot of benefit. And there are supplements and things that you can add in as well. But I would suggest that if you're going to do that, you speak to a nutritional therapist or someone. And if you need some links for those, then have a look in the show notes, and I've got some suggestions for who you can go and see. If you want to go down the medical route as well, you don't have to do one or the other. You can do both together. But if you want to go down the medical route, then there's some things that I can offer. So the first thing is pain management. So if you don't want to go down the hormone route, which is the next chain up, you could start with pain relief. Now, anti-inflammatories are helpful because what they can do is they can help to calm down the inflammatory reaction that occurs every month leading up to your period. So the way that I tell people to take it is they take some kind of anti-inflammatory, be that ibuprofen, naproxen, mefenamic acid, in the 2-3 days before their period is due, and they continue it all the way through their period and then they can stop once things have settled. And this is so that we can get the anti-inflammatory properties working before we have, the big reaction which happens with your period. So we start a few days before and we work through. Obviously, that's not helpful if somebody's got very irregular periods or they don't know when their period's going to be. But it's something to try. Even if you try it during the period, it's worth giving a go. Now, not everybody can have these things. If you've got problems with gastric ulcers, for example, or a lot of reflux, you could try it if you wanted to, but I would suggest that you use it with some kind of acids pill like lansoprazole or omeprazole, something like that, to protect your stomach lining. And if you're asthmatic and you're one of the 20% that have worsening asthma with anti-inflammatories, then obviously you can't have it either. So, to be safe, I wouldn't try that. And then you've got other things like paracetamol and codeine as well. If you find that you only need it for a short period of time, codeine can be really useful. Not everybody responds very well to it, and it can cause constipation and dizziness and drowsiness. So it's not an ideal pill to be on long term. So short term, short bursts for each period can be used if you needed to. So that's kind of the pain relief sorted from a medical point of view. But other things that can help with pain relief would be things like a TENS machine. So you can apply that to your lower tummy, and that can help. What it does is it works on something called the gate theory. So essentially it kind of gives the nerves something else to do. So rather than firing off pain signals to you the whole time, you're using a different kind of nerve system that kind of blocks that fast pathway of pain that you experience. So it's not going to be perfect, but it certainly can help to reduce the sort of the severest of pain. So it gives you kind of like it takes the edge off things a bit. So a TENS machine can work very well. So you've got pain relief. Then you've got hormones. So hormones are not going to cure the condition. It's not like we give you the contraceptive pill and it cures adenomyosis. That's not how it works. What it does is we use the element of the progesterone that's in it, or the progestin, and that helps to calm down the lining of the womb. So rather than it thickening up, which is what the estrogen is there to do, to prepare your womb ready for when a baby comes, we use the progestogen properties to keep the lining of the womb thin. So it's almost like it's telling your womb that you're pregnant, or you don't need any womb thickening at the moment. It kind of switches it off, it calms it down. That's what it's doing. So if you're taking contraception, that can really help to reduce the cramps that you experience with the pain, because we're not bleeding as much, or we're not bleeding at all. So if you're using progestogen only pills, that can cause you not to have a period at all, which is safe to do. If you're on the combined pill, you can also have that same effect if you're taking the combined pill continuously, or you take it sequentially. So you take it every month and you have a break, or you take it every 3 months and then you have a break at the end of 3 months. So there's different ways that you can take the combined pill. So we're working on the premise that we're reducing the contractions of the womb and reducing the bleeding, which hopefully means that you are more comfortable. You might not completely get rid of the problem, but we're more comfortable. Yeah, so that's how your hormones work. So that's just pills, though. You can have injections and patches, rings. There's also the Mirena coil or other hormonal coils that you can have inserted as well. These are all very helpful, but the problem is each of these contraceptions have different properties and they have different side effects as well. So you need to make sure that whichever one you're being put on is safe for you. So if you've got blood clotting problems, a liver problem, history of severe history of breast cancer in the family, you wouldn't be able to have something that contained estrogen, for example. You'd go on the progestogen only. You can have a coil or something like that. If you take anti-epileptic medications, there'll be some things that you can't have. So you have to be really careful about what ones that you try. But there are lots and lots of options available, and it's something that you can come and have a discussion with me about, either through the Lowdown, which is a website that offers contraception advice. I work for them, or you can come and see me privately in the Female Health Doctor Clinic, and we can talk about potential options if this is something you'd like to try. So we can go down to the hormone route. That would be the next route. And then beyond that, you'll need a gynecologist. So a consultant who works in gynecology can give you what's called a chemical menopause. So we use something like Prostat or Zoladex, something like that. And what that does is it effectively switches off the hormones that are leading you to have a period each month. So it basically floods your brain with, it's called a GnRH analog or antagonist. So what it's essentially doing is it's essentially saying to your brain, right, we've got enough of this now, we don't need any more of it. So it down regulates. So it means that you're not the little receptors in your brain are not picking up on that hormone anymore. And because that's kind of shut off because it's got too much going in, it then doesn't feed into producing FSH, LH, which comes from the pituitary gland, and that tells the ovaries what to do. So essentially you switch off the bit of the brain that then drives everything else. So then that switches off the pituitary gland, which then switches off the ovaries. So essentially that's a long-winded way of saying it puts you into a menopause, a chemical menopause. So you will get menopause symptoms with these types of medications, and you'll need to have what's called add-back HRT. So some people might have actual HRT, so we might give you gel or patches, or you might need something called tibolone. Everybody's different. There's all different things we can try. Again, like the contraception, there are different properties that work for different people, that are safer for different people. So we need to make sure that we tailor it properly. But you need to have something, because if you have these downregulation medications, it can affect your bones long term. So it's not an ideal long-term solution, but it can give you short-term relief, and it can certainly help before you go and have surgery, because then it means that we've calmed everything down. So then when the surgeon does their bit, it's easier for them and hopefully a less invasive procedure for you as well. So rather than having maybe a tummy cut that goes right the way through the middle of your tummy, you might only need a C-section one, or you might be able to get away with having it done with keyhole surgery or vaginal surgery. So it can make a big difference, and some women really find it very beneficial. So that's switching off the hormones completely, and that's what you need a gynecologist to start, and then a GP like me can kind of continue that for you. And then you've got surgery. So surgery would involve removing the womb itself. And, you know, as you've seen from that picture, if you remove the womb with those elements in it, you've cured the problem, assuming there are no other things going on. Now, you can have your womb removed entirely. So that's also with the neck of the womb, with the fallopian tubes, and with the ovaries. But if you're young, you know, you're under menopause age, we wouldn't recommend that approach, because you need your ovaries with the hormones that they produce. So what you can do is you can have just the body of the womb removed, and you can leave the cervix behind, and you can leave the ovaries behind. I would also suggest that you ask that the fallopian tubes are removed. We used to just leave them behind with the ovaries, but we now know that the fallopian tubes are the source of where ovarian cancer comes from. So you remove the body of the womb and the tubes itself. Leave the ovaries in for their hormone properties, and then you can leave the cervix in, which can have beneficial effects for things like sexual intercourse and holding your pelvic floor in place. The only issue with that is that you still need to have smear tests, and you also need to make sure that if you are going on HRT later on, you test the cervix first of all to make sure that there's no remnants of endometrial tissue in there, and if you do bleed on sequential HRT, which is meant to give you a bleed, then you need to make sure that you continue with combined HRT for the rest of the time that you take it, or you have your cervix removed and then you eliminate that problem, and then all you need to do is take the estrogen. So I'm going to do more videos on HRT, because I think it's important to really get that you need to make sure that you're giving the appropriate regimes to the right people. And if you look on my YouTube channel, you'll see that I have already started doing videos on HRT and testosterone and things like that. So if you're interested, go and have a look at those ones and check back when I do some more. So there we have it. That's adenomyosis kind of in a nutshell, and it's very little known, little understood in the medical profession and in people generally. We assume that it's the same as endometriosis. Certainly I did when I was taught that, but we know that's no longer the case. And actually there is a lot you can do, both from your diet, your lifestyle, working with a nutritional therapist, you can have hormones, you can have surgery. So they're the different options, and I hope you found this useful. If you are interested in coming to discuss these things with me and you want to have a consultation, then have a look in the show notes and you'll see that there's a link to my clinic, a telephone number you can access as well. Get in touch with me and we can organise for you to be seen. I can also do investigations, blood tests, ultrasounds, MRI scans. All of these things can help you to find out if adenomyosis is your problem. So take care, and I look forward to seeing you again in another video. Bye.